Welcome to the ChiroUp 15 Minutes to Excellence webinar, where our goal is to provide you with useful new skills in 15 minutes or less. And this is consistent with the ChiroUp model, that regardless of your current challenge, whether it be profit, having enough new patients for growth, or a sustainable product that both insurance companies and patients want to buy, your foundation needs to be clinical results. And this is fueled through your skills and knowledge, and that's what we're here for today. I hope that you'll enjoy our webinar. This webinar today is Upper Cross Syndrome. It's part one of our Explosive Outcomes series, aptly named because clinicians who can identify and correct these 7 underlying functional diagnoses will obtain much better outcomes than those who can't. I think that traditional structural diagnoses focus on a tissue source for the patient's symptoms, like a facet capsule or a supraspinatus tendon, whereas upper cross syndrome and its components are functional diagnoses that require identification of the underlying factors that contribute to those structural lesions. And I think these problems are the conditions that give chiropractors a bad name, because if we continue to treat the structural lesions without identifying the underlying dysfunction, then the outcomes tend to not be as good. So the first one we'll talk about is upper cross syndrome. This was first described by Vladimir Janda in 1979 as a predictable pattern of alternating tightness and weakness involving the neck and shoulders. And this is a frequent contributor to neck and upper back pain. Janda recognized that this upper quadrant dysfunction didn't occur at random, but rather in a predictable pattern of tightness and weakness as the body attempted to balance itself. And upper cross syndrome typically starts because of flexor-dominated postures, which oftentimes we'll call a forward head, forward shoulder posture. And this process begins in the classroom as a child and progresses with age throughout the working years, because most occupations from computer operator to manual labor are flexor-dominated, and workstation users are particularly predisposed from prolonged static postures. When the muscle group, especially the pec muscle and the upper trapezius muscles, are chronically tightened, they undergo a process called adaptive shortening, where they actually become shorter. And their antagonist muscles that oppose that action, in this case the deep neck flexors and scapular stabilizers, become longer and weaker over time. And this is based on Sherrington's law of reciprocal inhibition, where a muscle that undergoes prolonged shortening will cause its antagonist to undergo relaxation or weakening. And Janda was able to identify postural muscles that are predisposed to adaptive shortening, and that includes the trapezius, the upper trapezius, levator, SCM, and pec major. And then the antagonistic phasic muscles that are predisposed to weakening would include the rhomboid and serratus anterior, which are the scapular stabilizers, along with the scalenes, middle and lower trapezius, and very importantly the deep neck flexors. And the term upper cross syndrome was coined because a line drawn to connect the tight muscles forms a cross with a second line drawn to connect the weak muscles. We often think of this as a forward head / forward shoulder posture. And if we think of this example here with a post and a bowling ball and a muscle, if the spine is the post and it's completely upright and the head is sitting directly on top of that post, it takes very little to no effort from the muscle to keep it in that position. But if we dump the shoulders forward and now the head rolls off the front of that post, now it requires strong muscular effort all day long to maintain that posture. And in this case, it's not a basketball, it's more like a bowling ball. So that's a lot of contraction throughout the day. It leads to muscular fatigue, but it also leads to other joint problems with something called centration. Centration is means optimal surface relationships between a joint, and this is a dynamic process which maintains the most stable relationship throughout a range of motion. In order for a joint to function properly, it needs to be centrated. If there's muscular weakness or imbalance, like a forward head, forward shoulder posture, that moves the joint from its centrated position, and what happens to an uncentrated joint is what we as chiropractors treat on a daily basis. That's sprains and strains, joint dysfunction, discogenic pain, the conditions of vertigo, TMD, rotator cuff syndrome, and oftentimes cervical and thoracic intersegmental joint dysfunction, but that forms in a self-perpetuating cycle. So that's why it's critical that we can identify upper cross syndrome and its relationship to the thing that we most commonly treat. So how do we identify it? First of all, it would be an assessment of static posture with visual inspection. The ideal standing posture is a line drawn from the ear through the shoulder, the greater trochanter, and just anterior to the lateral malleoli. Patients with upper cross syndrome often have a forward head posture where their chin is jutting forward, and a hyperkyphosis for increased stress on the back. There's oftentimes scapular winging as well, particularly the inferior angle of the scapula. It's often easy to identify the hypertonicity of upper cross syndrome. By palpating the muscles, we can see that there are going to be trigger points and they're hypertonic. That's a simple process, but identifying weakness is a little more challenging. Fortunately, there are a couple of tests that assist in that process. The neck flexion test would identify abnormal neck movement from weakness of the deep neck flexors, and this test is performed in a supine position. We're going to have the patient first perform a chin tuck, and then they're going to lift their head several inches off the table to look at their toes. And the normal pattern would be chin tuck with a smooth reversal of the normal cervical lordosis. An abnormal screen would be the patient leading with their chin, the chin jutting forward into protraction because of overcompensation from the SCM muscle. Another useful test is the deep neck flexor endurance test, and this test is performed by having the patient undergo chin retraction and then lifting their head off of the table just an inch or two. And the clinician's then going to observe for the patient's head to drop, and you can look at the skin folds of the neck. When you see those opening up, the patient's dropping their head, and you can give them one reminder if they start to drop their head, but if they continue to drop it, or if their head drops down onto your fingers, then that indicates deep neck flexor weakness. The average endurance for men is 40 seconds and for women 30 seconds, but those patients with neck pain average closer to 20 seconds, and this is a critical component of upper cross syndrome. Another key component is scapular weakness, and this can be assessed with the quadruped rock test. The patient is on all fours, they shift forward and backward and side to side, while the clinician observes for winging of the scapula, particularly the inferior medial border. As chiropractors, we're masters at identifying joint dysfunction, and upper cross syndrome tends to produce a very predictable pattern of joint dysfunction involving the atlanto-occipital joint, the C4-5 joint, the C7-T1 joint, T4-5, and the glenohumeral joint. And this is where we as chiropractors sometimes get into trouble, because we address the joint dysfunction very well, but we're not addressing the muscular component. And that muscular component can't be the patient thinking about better posture, because that's only going to last for a second or two until their conscious focus shifts back to something else, and then they drop back into whatever's neutral. So we need to change the patient's neutral posture. Part of that's going to happen passively by us stretching and performing myofascial release at the hypertonic muscles like the SCM, upper trapezius, and levator muscles. A lot of times there will also be adhesions that are going to develop in the scapular stabilizers, the lower trapezius, the serratus anterior, and sometimes even the scalenes. And so we're going to need to release those adhesions. The levator is one of the keys to this process. It attaches from the upper cervical spinuses down onto the angle of the scapula, develops trigger points in the muscle belly, and performing stretching and release of that muscle is useful. Similar process in the trapezius muscle, as well as the pec major muscle. So the patient has issues with the postural hypertonicity and the phasic weakness. And Sherrington's law would suggest that we need to address the hypertonicity and lengthen the hypertonic muscles before we'll ever have success at strengthening the weak muscles. So the strengthening exercises are going to focus on the phasic muscles, and we're going to try to do that in functional patterns, because if we can groove new motion patterns, that's going to be much more successful than any other static strengthening. So the first exercise that we incorporate is cervical retraction. This means the patient's going to tuck their chin to create a double chin, hold that position for 3 to 5 seconds, and then return to the starting position. Another movement pattern is deep neck flexion, where the patient's going to retract their head and then lift their head, bringing their chin toward their chest to look at their toes. Hold that position for 3 to 4 seconds and relax and repeat. A great stretch at home that the patient will typically love is the levator stretch. In this case, they're going to rotate their head 45 degrees, look down at the floor, bring the same hand that they're looking at up over the top to provide resistance. They'll then push their head back into their hand against resistance without letting it move, followed by a gentle stretch of tractioning that muscle back down. The trapezius stretch performed in a similar fashion, laterally flexing to the side, sometimes sitting on your hand or tucking your hand behind your back, and then stretching the trapezius muscle. This can be performed as a contract, relax stretch as well. The pectoral muscles are a key component of upper cross syndrome, and these can be stretched bilaterally with a corner stretch, facing a corner, their palms on the wall just at or above head level, and the patient leans in to stretch those chest muscles. One of our favorite exercises is YTWL scapular depression, and it's named because the patient's going to move from a Y to a T to a W to L position. And so you can try this right now at home at your workstation. Raise your arms overhead into a Y position, contract the muscles in between your shoulder blades, and then drop your arms into a T position as you progressively increase the amount of contraction of those scapular stabilizers. Drop down into the W position, and finally the double L position. And patients will feel this. They can perform this throughout the day, very helpful. Another functional movement is the low row using an exercise band attached to a doorknob. This band is grasped by the patient with straight arms, and they pull their hands backwards. And finally, a Brugger with band. We've all heard of the Brugger relief position. This can be performed sitting or standing. The patient wraps or secures a band around their palms, forearms pointing forward, and the patient moves their hands apart from each other while pinching their shoulder blades together. I think a key component in the recovery of upper cross syndrome is ergonomic modification, that the patient takes a look at their workstation, and two of the biggest pieces are the monitor and the mouse. That oftentimes patients will move monitors further away than they should be, so that creates better space in front for them to drop files on their desk, but it also forces the patient's head then to move forward to get the ideal screen to eye visual distance so that they're focused. And so the body wants to naturally drop your head forward, and it's holding in that position all day long. Same thing happens if the monitor is too low. Obviously it's going to be dropped, whereas the ideal workstation monitor height would be the top line of type being 10 to 15 degrees below eye level or at eye level. The second problem that we see with patients with upper cross is they're contracting their trapezius muscle all day long to hold their arm up to reach their mouse. Ideally, they'd be able to drop their shoulder, drop their arm, bend their elbow at 90 degrees, and the mouse would be directly forward. If the mouse is elevated on a desk, or in this case even worse, they're contracting that trap, and that's obviously going to take away from what you're trying to accomplish. So how do we incorporate this into the patient's lifestyle? Well, here's how we do it. We take out this form, which is called a condition menu. It's available on the website, and I circle upper cross syndrome along with any other concurrent diagnosis, and I hand that to a staff member. They enter that information into ChiroUp, they print it and email it to the patient. The patient then has video demonstrations of their exercises along with all of the ADL advice, like the mouse and the keyboard and monitor height, as well as a whole bunch of other things that's going to help them recover quickly. And now you've made that patient an active participant in their recovery and seeing your outcomes improve. If you wish to review any of the assessments, treatments, or exercise videos that we covered today, or to learn more about upper cross syndrome, just log into your ChiroUp account, click on the Sharpen My Clinical Skills menu tab, navigate to Condition Reference, and select Upper Cross Syndrome. That'll bring you to our gray box where you can click on any of the components to view videos of detailed assessment, management, and exercises. I hope you've enjoyed today's presentation of Upper Cross Syndrome, and we look forward to speaking to you next week about another functional diagnosis.